Thank you very much. It's been wonderful to be here in Abu Dhabi, both professionally and personally. We're now going to have a sort of a change of pace. I'm going to be talking about epidemiology and the development of radiation risk coefficients that are used by the Protection Committee. And I'll be talking about specifically two recent studies of pediatric CT and cancer risk and what their interpretation might be. These are my personal views, and they don't necessarily represent the views of the ICRP or the NCRP or UNSCARE or Vanderbilt University or Harvard School of Public Health or the Health Physics Society of the United States or the Radiation Research Society. But you might pay attention. Here's what I'll be talking about. Why are CT studies in epidemiology? Why are they important at all? Then I'll talk about the UK study and something I hope when we leave this morning, you will all be very well informed on what reverse causation means. Reverse causation. Then I'll talk about the Australian study, and then in respect to Elicio and Committee 3, a little bit about dosimetry, and end up with some not confusion, hopefully some conclusions. A little slip there. CT exams are increasing each year. So despite the fact, as discussed, that the doses per CT are in fact dropping, the numbers are increasing dramatically, especially in the United States. If you can see this curve, last year in the United States, 84 million CT exams were performed. 84 million. Madat mentioned that there were 200 million in the world in the year 2008. So the United States uses CTs at a great rate. That's approximately 1 of every 4 citizens gets a CT every year. When I'm in an audience like this and discussing, I often ask them to raise their hand. Who's had a CT in the last year? This shows how predictive value of epidemiology and statistics is. If there's 100 people, I always get 25 hands. Always, doesn't matter. It is, CTs are very common in the United States. Also, one of the reasons why for many years we've been focusing on CTs, it's not just it's a very important diagnostic procedure where the numbers are increasing by year. These are not your grandfather's chest x-ray. These are doses that can be meaningful, not having 1, but if you have 5 or 10, if you have a lot of CTs, you can get into the range where epidemiology has some ability to actually identify risks. 1 or 2, not so. Many, and you can just look at these comparisons. The lung chest x-ray 0.15 milligray, an abdominal CT 20 milligray. Just whether it's 10, whether it's 5, it's 20, it's a lot compared to just a simple chest x-ray. So why are these studies? Why are we studying these populations now? Well, it's a very common procedure, and they have the potential to provide new information on radiation risks. I mean, these studies of children or adults who have multiple CTs have the potential to provide information on radiation risks. They're relatively high dose. But also, as Kimberly mentioned, they draw attention to the fact that these are procedures, there's a continued vigilance. We need to reduce the dose. And there's been great experience, particularly with children. They used to use adult parameters to do CTs on children. That was one of the big changes One size doesn't fit all. Don't use adult procedures when you're dealing with a child and you have dose reduction. Also, the studies too, they increase our awareness that we can reduce the dose for the image quality that's necessary for the diagnostic procedure. Now I'll move to some of the first study. This is the UK study of CT examinations and leukemia and brain cancer, and then I'll give you a feeling, a discussion of reverse causation. This study was published in a prestigious journal, The Lancet. It was a record linkage study of over 178,000 individuals under the age of 22. I'll get back to this. This is called childhood CT of exposures under the age of 22. The collection of the scan data for individuals was not possible, the individual parameters, so national surveys and general parameters were used to estimate doses, and dose-response relationships in the milligray range were reported, as shown on these slides. These are rather remarkable because they're the highest risk coefficients I've ever seen. They're enormously high. I want you to get a feeling. I'm a radiation epidemiologist. I've been studying populations for over 40 years around the world, and these are the highest risk coefficients in children or in any study that, relative risks at 1 gray on the order of 30 are enormous. They're just enormous, which then questions the reality. Here is the major limitation of this study as well as the Australian study. The major one is the indication for the examination is not known. The indication for the exam is not known. Children that get 5 and 6 CTs of the head, they're not well. It's a very basic point. This is what unscare. Ferret, it's being presented tomorrow at the General Assembly Committee. But the Unscare report on childhood cancer, which will be coming out very shortly, and the consultant was Fred Mettler, who is emeritus member of the main commission and former chair of Committee 3. There are concerns about the risk estimates because of lack of information about the indications for the CT scans and the consequent potential for reverse causation. That is, cancers may have been caused by the medical conditions prompting the CT examinations rather than the CT exams themselves. In other words, it was the symptoms caused the X-ray. The X-ray did not cause the cancer. And also there's a concern about individual dosimetry, as in the recent Unscare report. The National Council on Radiation Protection and Measurements also came out with a report last year. It was chaired by Julian Preston, former committee chair of Committee 1. And this is their evaluation. Children who receive frequent exams may have some underlying disability related to the outcome of interest. That is, a child who receives multiple CT exams of the head may have a central nervous system disorder that is prompting such examination that eventually leads to a cancer diagnosis. In other words, it's the condition prompting the X-ray, not the X-ray causing the condition. And this is called reverse causation. The fancy epidemiology term is confounding by indication. So the big problem with this study and the Australian studies is the reason why the exams were performed was not known. That's now, then you say, well, that's well and good. I'm kind of familiar with epidemiology. It's always presented that the epidemiology says such and such. Well, is it theoretical? Does reverse causation ever happen? Yes. And here is a study of thyroid cancer following scans, I-131 scans of the thyroid. And this was done, we set it up in the 1980s. And it was set up by Lars Erik Holm, who was the former chair of ICRP, the main commission. And 35,000 adults were scanned with I-131, and the risk of thyroid cancer later in life was evaluated through these wonderful systems in Scandinavia, the record linkage, the cancer registry. We went into 7 of the hospitals in Sweden and abstracted all the clinical information on why the exam was performed, thyroid size, administered activity, so we could estimate the doses. Here's the result, okay? Reasons, I'm going to go through just 3 simple slides. Why was the exam performed? This is for all reasons. This would be the same if we did not know why the exams were given and just published. We would see a relative risk, of 1.8 overall. That's almost a doubling of risk compared with the general population. And this shows the time after the CT exam. 2 years, 5, 10, 20. You see it's elevated even 20 years after exposure. Long latency makes sense. 1.8. The other thing that gave us pause, though, this is for adult thyroid exposures, and the adult thyroid is not considered very radiosensitive. It's really the child that gives us the high risk. So this gave us a little pause. We then looked at, what about the group that was scanned because there was a suspicion of a tumor, a nodule? Okay? Now, if you look at this slide, if you just look at the group that was scanned because they thought there might be a tumor, that was the clinical indication, the risks are double from the overall risk. Now we're almost getting 4-fold risk. It's not surprising, and this goes to the other studies. If a child, someone comes in for an examination and there's a suspicion of a tumor, sometimes that tumor develops in the subsequent years, or it's detected right at the time. Here, 20 years later, there's still a significant excess. Okay, now if you'll bear with me, I'm going to show you one more slide. Guess what it's going to be? What about the group that received the scan? What about the group that received the scans for reasons other than tumor? So if you see, this is everybody, then suspicion of tumor, and this would be everyone else. So if there is a risk of I-131 exposure, you should see elevated risks. If there's no risk for I-131 exposure in adults, similar to what's been seen in so many other studies, there should not be a risk. And if you look, is that when we separate out the reasons for the exam and those for other reasons, it's normal risk. These were people who are scanned for hormonal reasons or other abnormalities. These are very large numbers, too. This group was much larger than the suspicion for tumor. They just had fewer thyroid cancers. No excess risk is scanned. The other thing just to mention is this prediction of clinical indication. It just is not the next year. Even in this group, for all reasons, suspicion of tumors, the tumors may take 10, 15 years to develop. So it's very, very difficult without knowing the reason for indication, how to interpret the data. It gives you pause. Now, many of you know my wife, Jennifer. She was unable to come. And this is my son. My son is 21 that just graduated from college. The studies that have been highlighted are, this is the title, Radiation Exposure from CT Exams in Childhood. Okay? I can assure you, a 21-year-old is not a child, and it's not what we think of in terms of radiation sensitivity. Completely different, completely different. Now, here's another epidemiologic concern. Children are more sensitive than 20-year-olds, right? I mean, to radiation. This is what, at least for many tumors, particularly of the brain. But if you look at the UK study, it's just the opposite. The young children, and these are risk estimates, which are still very high, they had the lowest risks, and the teenagers, which are included in the study, they had the highest risk. Unscare report, which I recommend for everyone to get next week when it's available, clearly shows that glioma risk is highest for the very young. It's clearly the case. And when you get older, your brain is more developed, and the risk drops precipitously for adult exposures to the brain, particularly in the low dose. So this is inconsistent. The findings are inconsistent with the literature. Also mentioned, we know a lot about radiation-induced brain cancer. The risk coefficients I mentioned are astronomically high in compared to other studies, such as these studies of Israeli tinea capitis children who are irradiated. Even comparison with the A-bomb survivors, they're 20 times higher. That gives you pause on the causal interpretation. Very quick, we know, and just to give you a sense, we know a lot about radiation-induced cancers. Epidemiology has been studying populations for over 100 years. This is not an absence of information. We don't know very much about low doses, but at moderate to high doses, we really know a lot. And just look at the studies. I just want to give you a sense that we're not in a vacuum here. The reports that Unscare, ICRP, the National Academy of Sciences that are reviewing, they're reviewing a tremendous amount of literature, including childhood exposures with thymic irradiation, tonsils. Tremendous. Just for completion too, I'm going to skip this with the absence of time, but one could, there was questions about the leukemia risk even in the UK study because of the inclusion of myelodysplastic syndrome. The fact is just that if you remove myelodysplastic syndrome from the analysis, the finding is no longer significant. Going to move to the Australian study and wind down very quickly. It should be easy because I'm essentially going to repeat what I've just done, what I've just said about reverse causation and the unusual risk coefficients. But one of the things, and now this is the, they did a data linkage study. It's enormous. 11 million people are evaluated. This is huge, but it's just record linkage. And they report excess cancers related to CT to practically every cancer known to man. This gives you pause. Look at the list. Digestive organs. Melanoma. Melanoma is not known to be caused by ionizing radiation, okay? It is not accepted risk. Soft tissue sarcoma. Sarcomas are caused by radiation, usually radiotherapy, high doses. Female genital, urinary tract, brain. Here's a grabber, brain. And I hope Bill Morgan might be in the audience. It didn't matter if you had your CT to the brain or your CT to the abdomen. It increased your risk of brain cancer. This is the extreme example of the bystander effect. You can irradiate. Really, I'm trying to be facetious, but this is so inconsistent with knowledge. The dose to the abdomen increases your risk of brain cancer. Thyroid, leukemia. Myeloid leukemia was increased, but not lymphoid leukemia, which is a big risk factor, and then Hodgkin's lymphoma was increased, which is not known to be increased by radiation. This all gives you pause on interpretation. Then, so you had the increase of everything except the sites I would have predicted. Breast cancer, one of the most radiosensitive sites that we know, particularly with young girls. There was no increase at all. And lymphatic leukemia, very high risk coefficients, not increased, gives you pause. Now, this is being presented, I forget which time zone, either today or tomorrow, for the General Assembly in the United Nations. It's the wonderful report coming out of Unscare on the effects of radiation on children. So I've mentioned that before, just to mention. The Unscare has weighed in on this study also, saying, you know, this reverse causation seems to be a problem. You don't know why the exams were caused. Sick children do not get 3, 4, 5 CT exams. There's clinical indications why that happens. So there's a potential bias that could explain all the results. Also, they stress that the risk coefficients are statistically incompatible with the study of the Japanese atomic bomb survivors, as well as every other study. So the studies here of 27 for all solid, versus perhaps 3 with children, and it's just not plausible that that could be that high. Also, the latency is too short. For radiation, it does not cause cancer immediately. It doesn't cause it within 1 year. When we look for solid tumors, it's 5 years, it's 10 years. I'm coming down to the wire. So there's this concern, not the stage, but it's implausible. Radiation doesn't cause cancers immediately. You have to wait 5, 10 years for the solid tumor. So this is not plausible. I mentioned breast cancer. This is something that I've studied for over 40 years, and we find clear evidence for risk of radiation-induced breast cancer in young women, in children, in newborns, in women with scoliosis, monitoring for tuberculosis. And the fact that they do not find this most sensitive site is rather remarkable. The age at exposure is just also the opposite. Here's unscare. You affect, for leukemia, that the younger children are the highest risk. In the Australian study, the younger children had no risk. So how can this be? It doesn't make sense, epidemiologically. Now I'm going to finish, and I wanted, perhaps Alicio can now help me, because I wanted to explain, just a few minutes, the dosimetry that's involved in CT scans. And so it's very complex, and Wes is here, so perhaps we could go one of these, But dosimetry is very, very important. It's very challenging. I mean, it really is. And there was no individual dosimetry. There was two major types of CT machines. One is conventional machines in the early days that would go on for, 30 minutes. The helical machines today can go on for a minute. Doses can be completely different, from the old machines and the new machines. There's a possibility of missing examinations, repeats. In the old days, the images would be blurred and they'd be repeated, but they're not recorded in the epidemiologic study. Here's the conclusion, my last slide, so thank you very much. Current studies, this is sort of the take-home message, do not provide evidence that low doses are causally associated with cancer. So these studies, even though they're published in prestigious journals, they don't provide evidence. There are associations, but they are not, should not be interpreted as causal. Why? Reverse causation seems very likely, and there's so many epidemiologic inconsistencies with age at exposure, latency, tumor sites, radiation risks. These are all inconsistent with the world's literature. They're just too extreme. Individual dosimetry is key. It's not been done. And one hopes that in the future, the studies that are ongoing with CT exams will try to take into account why the exams were given, just like we did in Sweden for I-131 examinations. Thank you very much.